Let me record the lecture and I will start. Okay, today's lecture is about mood disorders, anxiety disorders, and psychotic disorders. So let me start with the mood disorders. Mood disorders uh, are classified into the several subtypes, and this classification is according to the DSM-5. As I mentioned, DSM-5 is a statistical manual of mental disorders, and if we want to find out what is the classification of mood disorders or any other mental disorders, you have to refer to this statistical manual, DSM-5. So according to DSM-5, mood disorders are divided into several types, and these are major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, subclinical depression, bipolar disorder 1, bipolar disorder 2, and cyclothymia. So these are the subtypes of the mood disorders. Let me just explain what does it mean, each of these disorders. Major depressive disorder. Why it is a major depressive disorder? It is a major depressive disorder because it lasts at least 2 weeks and more than 2 weeks. So what are the symptoms of the major depressive disorder? The major symptoms are sad mood or loss of interest or loss of pleasure. Loss of pleasure, another term is anhedonia. You know already this term from the schizophrenia. Anhedonia is a loss of pleasure. So these symptoms are present nearly every day, most of the day, at least 2 weeks, and even more. And plus 4 following symptoms should exist to make a diagnosis of the major depressive disorders. These are sleeping too much or too little, psychomotor retardation or agitation, poor appetite and weight loss or increased appetite and weight gain, loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating, thinking or making decision, and recurrent thoughts of death and suicide. So these are the necessary symptoms which should exist to identify and make a diagnosis of major depressive disorder. As I mentioned, these symptoms should exist nearly every day, most of the day, at least 2 weeks, and even more, at least 2 weeks. So 4 of these symptoms is necessary should exist to identify these diagnoses. Another subtype is a subclinical depression. So subclinical depression, it's still a depression, and 3 of the following symptoms should exist for at least 10 days. So what is the difference between the major depressive disorder and the subclinical depression? The difference is between the number of the symptoms and the duration of these symptoms. If the major depressive disorder lasts 2 weeks, subclinical depression should last 10 days. And if it is necessary 4 symptoms for major depressive disorder, for subclinical depression, it is necessary 3 of the following symptoms I just mentioned. So that's the only difference between the subclinical depression and the major depressive disorder. Another subtype of mood disorder is the persistent depressive disorder. Persistent depressive disorder. Persistent itself, the term is telling you that this is a chronic disorder. It lasts for a long period of time. That's why it's persistent. So it lasts at least 2 years in adults and 1 year in children. So persistent depressive disorder lasts 2 years, and 2 of the following symptoms is necessary to exist to identify the persistent depressive disorder. The symptoms I just told you, what are the major symptoms? Once again, I will tell you these symptoms of depression: sleeping too much or too little, psychomotor retardation or agitation, poor appetite and weight loss or increased appetite and weight gain, loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating, thinking or making decision, and recurrent thoughts of death or suicide. These are the classification of symptoms which are necessary for the depressive disorders. So once again, the persistent depressive disorder is different from the major depressive disorder and the subclinical depression with the duration. It lasts 2 years. And with the number of symptoms, it is necessary only 2 symptoms to exist to identify the diagnosis of persistent depressive disorder. So another type of the mood disorders here is the premenstrual dysphoric disorder. Premenstrual dysphoric disorder, it is the condition which exists before the menses. So after the menses, these symptoms of the depression will disappear. But before the menses, the symptoms occur. So 5 of the following symptoms is necessary to identify the premenstrual dysphoric disorder. 5 of the following, and you know these symptoms already. So 5 symptoms is necessary to exist to identify the disorder of premenstrual dysphoric disorder. So what is the reason of this? This is the reason of the premenstrual dysphoric disorder is the hormonal disbalance, which affects then the mood and regulation of the mood. And as I mentioned, the major neurotransmitter which is responsible for the mood regulation is serotonin. So the hormonal disbalance, the general systemic hormonal disbalance, may affect on the levels of the serotonin into the brain. So it means that the general hormonal disbalance will change the biochemistry of the brain and can cause the premenstrual dysphoric disorder. But after the menses, when the menstrual cycle will end, everything is regulating and all the symptoms of the depression will disappear. So this is kind of condition, the premenstrual dysphoric disorder, but it still is a mood disorder. It is included into the classification of the mood disorders. The next and very important disorder which is included into the mood disorders is bipolar disorders. So bipolar disorders like schizophrenia is an endogenous psychosis, but it affects the mood, and that's why it is included into the mood disorders. Bipolar disorders, it's purely genetical disorders. So the statistics of bipolar disorders, it's like 90%. It is 90% inherited disorder. The major depressive disorder, it's only a 30% 30% inheritance is necessary to identify the major depressive disorder. It means that partly on major depressive disorder influence the environment, and partly it is genetical. But for the bipolar disorder, it is purely genetical disorder, like in schizophrenia. Schizophrenia is also a genetical disorder. So bipolar disorder is divided into several subtypes. So this is the bipolar 1, bipolar 2, and the cyclothymia. So why this difference between the bipolar disorders? It is, of course, related to the symptoms and to the severity of the disorder. So bipolar 1 is the most severe subtype of the bipolar disorders. So bipolar disorders are the cyclic disorders. Cyclic, what does it mean? The mania, the state of mania, turns to the state of depression. So these are the cycles, mania and depression. So what does it mean, a manic state of the mind? Manic state of the mind means the elevation of mood, elevated mood, too much increased mood. This is the mania. And the depression, you already know what does it mean, the depression. Depression is the permanent sad mood. So these bipolar, that's why the term bipolar means two polar states of the mind. That in one point, the mind of the human is in manic state, and another situation, these manic states turn to the depression. So what is the difference between the bipolar 1, bipolar 2, and the cyclothymia? As I mentioned, bipolar 1 is a very severe subtype of the bipolar disorders. So in bipolar 1, manic state lasts at least 1 week. 1 week should this manic state last to establish the diagnosis of the bipolar 1. And then this manic state turns to the depression, okay, the deep depression. And in bipolar 2, we already have the hypomania. What is the difference between the mania and the hypomania? In mania, the person might have the psychotic symptoms like during the schizophrenia, hallucinations, delusions. These are the symptoms of the mania. But in hypomania, we still have the elevated mood, but without the psychotic symptoms. You have to remember the difference between the mania and the hypomania. And that is the major difference between the bipolar 1 and bipolar 2. So in bipolar 1, we have the hypomania, which lasts at least 4 days, and we have the major depressive disorder. The cycle of hypomania turns to the major depressive disorder. And the cyclothymia. Cyclothymia, it is the mild version of the bipolar and bipolar 1 and bipolar 2. Mild version, it means that we have the hypomania and mild depression. Okay, and it lasts chronically, like persistent depressive disorder. The cyclothymia lasts for 2 years. So once again, let me just summarize what is the difference between the bipolar 1, bipolar 2, and cyclothymia. In bipolar 1, we have 1 week of mania, which turns to deep depression. And this depression may last 1 month, 2 months, 3 months, and then again we will have the manic state. In bipolar 2, we have hypomania and a major depressive disorder. In cyclothymia, the hypomania lasts 4 days and then it turns to the depression, which still may last 1 or 2 months. And again, the depression can turn to the hypomania if it is a bipolar 2. And then we have the cyclothymia. Cyclothymia is a milder version of the bipolar 1 and bipolar 2, and the symptoms of the cyclothymia are hypomania and mild depression, which lasts for 2 years. Okay, so besides these major symptoms, at least 3 of the following symptoms should exist to identify the bipolar disorders. These are increase in goal-directed activities or psychomotor agitation. This symptom is related to the manic state. Unusual talkativeness or rapid speech. Flight of ideas or subjective impression that thoughts are racing. Increased self-esteem. Distractibility, attention is easily diverted. Excessive involvement in activities that are likely to have undesirable consequences, for example, uncontrollable sexual behaviors or driving in very high speed. These are the symptoms which are related to the manic state. If you, for example, observe these symptoms, you may understand that you are dealing with the manic state. Okay, these are the symptoms of the manic state. Then, as I mentioned, the mania turns to depression. This disorder is a cyclic disorder. These are cycles of mania and depression. So now I would like to focus my attention to the neurobiology of the mood disorders. So the 3 of above mentioned disorders, the depression and the neurobiology of the depression is different from the neurobiology of the bipolar disorder. But the neurotransmitters which are participating in the depression and in bipolar disorders are almost the same. Okay, we have 3 major neurotransmitters which are playing a crucial role in depression, in major depressive disorder, in subclinical depression, and in persistent depressive disorder. These are norepinephrine, dopamine, and serotonin. So all these 3 neurotransmitters are in low levels. So we have low levels of these major neurotransmitters during the major depressive disorder, persistent depressive disorder, and the subclinical depressive disorder. So what's going on in bipolar disorder? We have the manic state. So in manic state, we have increased levels of norepinephrine, dopamine, but decreased level of serotonin. And what happens during the depression in bipolar disorder? All the same that happens during the major depressive disorder. All these 3 neurotransmitters, the levels of these neurotransmitters are decreasing. So in major depressive disorder, persistent depressive disorder, and subclinical disorder, we have low levels of norepinephrine, dopamine, and serotonin. In bipolar disorders, manic state, we have increased levels of norepinephrine and dopamine, but decreased level of serotonin. In the phase of depression, during the bipolar disorder, we have low levels of norepinephrine, dopamine, and serotonin. That's the major difference between the mood disorders and between the neurobiology of the mood disorders. Now let me tell you the psychological factors that may influence on the mood disorders. As I mentioned, major depressive disorder can be influenced by the environment, can be triggered by the environment. Some psychological factors, stress, interpersonal relationships, psychological traumas, all of these factors may trigger the major depressive disorder. So mainly women are prone to the depression than the men, because women are more sensitive in their psychologically they're very sensitive. That's why the reaction of the women is more severe to some stressful situations and stressful life events than the men's psychology. That's why women are more prone to the depression than the men. So I can't tell you the same about the bipolar disorder. The bipolar disorder affects equally men and the women. So it's different than the depression, for example. Bipolar disorder is 90% inherited, and no psychological factors can cause the bipolar disorder. But psychological stress or social stress can trigger the bipolar disorder. The psychological stress can increase the risk of manifestation of the bipolar disorder, but cannot cause the disorder. The cause of the disorder is purely genetical. It is programmed genetically. So that is the difference between the depression, the major depression, and the bipolar disorder. There is also a psychological point of view about the major depressive disorder. And as I mentioned before, you know the CBT. What does it mean, the CBT? Cognitive behavioral therapy and cognitive behavioral theory about the manifestation of the depression. So it's called the Beck's triad. Beck's triad. So what does it mean, the Beck's triad? There is a negative schema, then there is a cognitive basis according to this negative schema, and then a depression. So let me explain you what does it mean, this Beck's triad. Negative schema, it means that the person has the negative schema of the worldview of him or herself and the life generally. So this negative schema, which is inherited in the personality, influence on the cognitive functions, on thinking, on perception, on the establishment of the worldview. So if you have the negative basic schema in your mind, it will influence on how you perceive the world, right? It means that you will perceive the world in the negative scope. So then this negative worldview will influence on your condition. It means that you will easily get to depression. And you know that the negative thoughts then affects the biochemistry of the brain. So if you have the permanent negative thoughts about the world around you, about perception of your personality, if you have these negative thoughts, at the end, it will decrease the level of serotonin, norepinephrine, and dopamine. So it means that our cognitive functions, our thoughts, our perception will influence on our neurophysiology at the end, and we will get the depressive personality. This is the Beck's cognitive theory of the depression. Okay. This is one of the explanation of the depression, but of course it is not that easy to explain the depression only in this cognitive behavioral scope. But this is one of the theory. So now, how we should handle this depression and the bipolar disorder? Of course, there is a treatment of these disorders. If would like to treat the depressions, the major depressive disorder, the persistent depressive disorder, and the subclinical depression, the treatment options almost are the same for these disorders, because we know that the neurobiology of all these disorders almost are the same. And we know that the basis of these disorders are low levels of norepinephrine, dopamine, and serotonin. So we may just use antidepressant drugs, MAO inhibitors. We may use tricyclic antidepressants, which are acting on these neurotransmitters non-selectively. We may use the selective serotonin reuptake inhibitors. These are very effective drugs nowadays, because mostly scientists think that serotonin plays the crucial role in developing the depression. So the SSRIs, the short abbreviation of the selective serotonin reuptake inhibitors, are very effective in treating the depressions. And plus, of course, we can combine the pharmacological treatment of these disorders with the CBT, cognitive behavioral therapy, or the psychodynamic therapy. Psychodynamic therapy is a type of the psychoanalysis, but the contemporary type of the psychoanalysis. It lasts for 2 weeks. You know what is the mechanism of the psychoanalysis, the free association, interpretation of this free association, and interpretation of the dreams. So the same mechanism is involved in the psychodynamic therapy, and we can use psychodynamic therapy to treat the depression. Sometimes people need to realize what are their problems that are hidden from the consciousness. And if they make conscious their hidden problems, these can be helpful for the person to solve their problems and get rid of the depression. Okay, so the treatment of the depression is using the antidepressant drugs of different mechanisms. It depends. It's very individual, and the psychologist or the psychiatrist should choose these drugs according to what type of depression the doctor deal with. And plus, combination of CBT, once again, I tell you that this is the only one evidence-based method which is used to treat the depression, and it's very effective, especially in treating the depressions. So this is the major treatment options of depressions. But now I would like to focus on bipolar disorders. As we know, the bipolar disorder has cycles of manic states and the depression. So the depression, the phase of depression, we are treating with the same medication as we are treating the general depression. But the manic state, if we have the bipolar one, we know that we have acute manic state with the hallucinations and delusions. So we should use two types of medications, and these are neuroleptics. You know that antipsychotic drugs are used to diminish the hallucinations and delusions. And plus this alleviated mood, we should stabilize somehow with the mood stabilizers. And the very effective drug is used to stabilize the mood, and this is a lithium. Maybe you've heard about the lithium. But nowadays, lithium is not used that frequently because it is very toxic, and other mood stabilizers are used. For example, valproic acid. Valproic acid is also anticonvulsant drug, which is having the mood stabilizer properties, and we are using these anticonvulsants to stabilize the manic state. So if we have bipolar 1, acute manic state with a psychotic symptoms, we are using combination of neuroleptics plus mood stabilizers. If we have the phase of depression during the bipolar disorder, we are using antidepressant drugs plus mood stabilizers. Why plus mood stabilizers? Because there is a risk of turning depression into the manic state. Why? Because during the depression, we have low levels of norepinephrine, dopamine, and serotonin. And by just adding the antidepressant drugs, we have a chance to increase the level of these neurotransmitters and turn the phase of depression to the phase of mania. Okay, so that's why we need to add a mood stabilizer, which will stabilize the effects of the antidepressant drugs and will help us to avoid and to prevent from the manic state, turning the phase of depression into the manic state. So two types of medication we are using depending on which phase the person is during the bipolar disorder. If it's a mania, we are using the neuroleptics and the mood stabilizers. In bipolar 1, once again, I'm repeating. And if it's a depression, mood stabilizers plus antidepressants. Now, if it is a bipolar 2 or cyclothymia, as I mentioned, during the hypomania, we do not have the psychotic symptoms. So there is no necessity to use the neuroleptics or antipsychotics, but there is necessity to use the mood stabilizers because still it is an alleviated mood we have during the bipolar 2. So we are using during hypomania only mood stabilizers. But if we have the depression, once again, we are using mood stabilizers and antidepressants. The same treatment options is for the cyclothymia, mood stabilizers and antidepressants. Okay. And plus, of course, we can combine this pharmacological treatment with the psychotherapy methods like CBT or psychodynamic therapy or family therapy. Depends. Okay, depends. So this is the information about the mood disorders, the general information about the mood disorders. Now, if you would like, we can just take a break for 5 minutes. And if you have questions, you can ask me the questions and I will answer your questions. If it was not that clear what I was talking about, I will try to clarify once again if there is some questions which are not that clear. No questions? Okay, let's just take a break for 5 minutes and I will continue. Okay. Okay, I will start now. Well, let's wait if someone join us. Let's wait 1 more minute and I'll start. Um, 8 weeks. The topics of 8 weeks will be covered on midterm 2. So we will have the second midterm on the 9th week. On the 9th week. So 1 more week. Week of not next Monday, but the other Monday. 1 more week we will have the lecture and then we will have the midterm 2. Okay, let me start now. Next topic is about anxiety disorders. And like with the mood disorders, anxiety disorders also divided into several subtypes according to the DSM-5. So these are panic disorders with or without claustrophobia or agoraphobia, specific phobia and social phobia, obsessive compulsive disorder, post-traumatic stress disorder and acute stress disorder, or PTSD and ASD, and generalized anxiety disorder. These are the anxiety disorders. So let me just explain what are the symptoms of each of these disorders and what is the treatment of these disorders. The first one is the panic disorder. So what's going on with the panic disorder? We know that during the panic disorder, the main symptom is the intensive fear. So anxiety expressed itself in unexpected ways. Okay, having fear, it's normal if it is a normal fear, normal range of fearful emotions. Fear is protecting us, right? But intensive hypertrophic sensation of fear during the panic attack, it is not a comfortable feeling. And it is led to the impaired functioning of the personality. So what are the symptoms of the panic attack? Intensive fear, and we have the physiological symptoms of according to this intensive fear. These are palpitations or increased heartbeat, sweating, shorten of breath, the dizziness, the fear of losing control and going crazy, the fear of death, feeling of nausea or abdominal pain. These are the symptoms of the panic attack. Okay. So now let me tell you what are the agoraphobia and the claustrophobia. During agoraphobia and claustrophobia, we still have the panic attack, which we'll get in 5 or 10 minutes after we get in the certain situation. Agoraphobia is fear of open spaces or crowded places from where it is difficult to escape. This is an agoraphobia. And the claustrophobia is the phobia of the closed spaces or confined spaces. Okay, so this is the claustrophobia. So this is a specific situation where the person, if he or she has the agoraphobia or claustrophobia, gets the panic attack. And what are the symptoms of the panic attack? Once again, sweating, palpitation, increased heart rate, increased breathing rate, fear of losing control, fear of death, and abdominal pain, nausea, in some cases even the vomiting. These are the specific symptoms of the panic attack with or without agoraphobia and the claustrophobia. So what are the treatments of the panic attacks in the agoraphobia and the claustrophobia? We were talking about the benzodiazepines. If you remember, benzodiazepines are the drugs which are inhibiting the central nervous system. Since the panic attack refers to the activation of the sympathetic nervous system, we need to decrease the activation of this autonomic nervous system. So we may use the beta blockers, which are decreasing the activation of the autonomic nervous system, or we may use the benzodiazepines. So remember, the benzodiazepines are the major drugs to treat all anxiety disorders. So what is the anxiety disorders? I explained to you the subtypes of anxiety disorders. So benzodiazepines, remember, that are the drugs, anti-anxiety drugs to treat the anxiety. So benzodiazepines acting on the GABA receptors, and GABA is the only inhibiting amino acid in our nervous system which is inhibiting the nervous system and which is calming the nervous system. Okay. And that's why the benzodiazepines, which are acting on the GABA receptors, helping with the anxiety disorder. So mainly we are treating anxiety disorders with the benzodiazepines. And in some specific cases, we may use the SSRIs. Why SSRIs? I just mentioned that SSRIs are serotonin selective reuptake inhibitors, which are increasing the levels of the serotonin. Why it is necessary to use the SSRIs when we are talking about the anxiety? Because anxiety disorders at the end led to the depression. So if it is anxiety disorder, which is comorbid with the depression or associated with the depression, we need combination of drugs, benzodiazepines plus SSRIs. That's why we need to add SSRIs if it is necessary. Okay. So next subtype of anxiety disorder in the classification of the anxiety disorders are the specific phobias in the social phobia. Specific phobias refers to, for example, for fear of specific things. animals, for example. Some people afraid of seeing blood. Some people afraid of needles, injections. Some people afraid of insects. So these are specific things, and people are afraid of these specific things. These specific phobias can be rational or irrational. There is a very paradoxical specific phobia, for example, fear of chicken or fear of birds. This is irrational. We do not have why it is irrational. We do not have explanation why the person afraid of birds, for example, because they are not dangerous, right? So they can't explain this. But there is a rational specific phobias we can explain. For example, fear of dogs. Why fear of dogs is more rational than the fear of birds? Because dogs can bite you and it's dangerous. You know that it's painful, it's dangerous, and you may even die because of the bite of the dog. And that's why it is more rational, more explainable, the fear of dogs. But it's still the specific phobia, and if the person has this specific phobia, we need to treat that person with a specific phobia. And what is the best treatment for the specific phobia? If you remember, I was talking about the behavioral techniques. And the most effective technique to treat the specific phobia is an exposure therapy. It is a step-by-step exposure therapy. I just gave you an example of spiders. If the person afraid of spiders, have the fear of spiders, for example, it's still a specific phobia of insects. We are just exposing these dangerous stimuli step by step, and the human mind is adapting to these dangerous stimuli step by step, and afterwards these dangerous stimuli will be neutralized, and the human mind will be adapted to this specific fear, and this fear will disappear. That's the mechanism of the behavioral technique, which is exposure therapy we are using to treat the specific phobias. This is the most effective treatment option. But of course, we can combine the treatment of the treatment of specific phobias with the pharmacological treatment, just using the anti-anxiety drugs, which are the benzodiazepines. Another phobia is the social phobia. Okay, the social phobia is a fear of it's a sociophobia. Okay, it's a fear of people. Okay, and if the person should, for example, demonstrate its abilities in front of lots of people, they will if they have the social phobia, they will have the panic attack. Okay. The same symptoms as we have during the agoraphobia, claustrophobia, the same symptoms of panic attack we may have during the social phobia, fear of people. So how we should treat the fear of the social phobia? We may use the beta blockers and anti-anxiety drugs. Plus, we may use the CBT here, the cognitive behavioral therapy. We should try to rearrange the thoughts related to this social phobia, that people are not that dangerous, and we should try to increase the self-esteem of the personality who is just trying to demonstrate the abilities in front of the lots of people. And if the self-confidence will increase and the self-esteem will increase, the person will diminish the fear of people in front of the lots of people, and the social phobia will disappear. But of course, we may use the anti-anxiety drugs plus the beta blockers. Next, subtype of the anxiety disorder is obsessive compulsive disorder. It is a very severe disorder. It's very annoying disorder for the person who is having the obsessive compulsive disorders. So main symptoms here, obsessions and compulsions. Obsessions are intrusive, recurrent thoughts, dangerous thoughts, and compulsions are some actions in response to these obsessions. So, for example, to reduce the tension from the obsessions. So let me explain you in more simple words, what does it mean, obsessions? As I mentioned, these are recurrent thoughts, dangerous thoughts. For example, the person afraid of something, for example, afraid of contaminated by germs. For example, these thoughts of fear of by contaminated by germs needs the compulsion, some action to decrease the tension from this obsession. And the person, what the person is doing, going and just washing hands several times, because this action will decrease the tension from the obsession. When the person is going and washing hands several times, he thinks that he will just get rid of these germs from the hands. So hand washing, ordering, cleaning, these are the types of compulsions in response to the obsessions. For example, ordering. Some people are obsessed with ordering. For example, they need that everything around them be in a specific order. If you destroy that order, they will be very upset. This is necessary for them, this order, because this order decreases their tension. And they again and again ordering the things. This is necessary for their brain to decrease the tension. They understand that this is a ridiculous action, but they can't get rid of this from their mind. They understand, they are very annoyed with their obsessions, but they can't get rid of this, just only with the compulsions. Cleaning, for example, it's the same, okay? People are afraid of different, this is a fear of dirtiness, okay? And they are afraid of being contaminated by some infectious agents. And that's why they are cleaning and cleaning and cleaning and reducing the tension from this action. So obsessions, once again, are recurrent intrusive thoughts, and compulsions are actions in response to these obsessions to reduce the tension which is caused from the obsessions. This is obsessive compulsive disorder, which is the anxiety disorder. So these people who are having the obsessive compulsive disorder are very anxious, okay? They have this anxiety disorder. That's why this disorder is included into the anxiety disorder. And at the end, this disorder leads to the depression. So here we need the combination of two pharmacological agents, the benzodiazepines plus the SSRIs. So these two drugs are used to treat the obsessive compulsive disorder. And plus, of course, the psychotherapy, like cognitive behavioral therapy, to change these distorted perceptions of the human mind related to some specific thoughts. Okay, they have some specific thoughts, and by the cognitive behavioral therapy, we will try to change those specific irrational thoughts with more rational thoughts, which then led to the rational behavior, and then these compulsions will disappear. So combination of pharmacological agents, which are the benzodiazepines and the SSRIs, and the CBT is very effective in treating the obsessive compulsive disorder. Next, in the list of the anxiety disorders is PTSD, or post-traumatic stress disorder, and ASD, or acute stress disorder. So what is the PTSD? PTSD, post-traumatic stress disorder, itself telling us that it is related to some trauma which happened in the person's life. So post-traumatic disorder, it's experiencing very traumatic feelings related to some past trauma event. So why it is very annoying, this post-traumatic disorder, because it is led to the impaired functioning of the personality. The person has the permanent flashbacks of the traumatic events. For example, post-traumatic disorder happens mainly with the soldiers who were witnessed very traumatic events. For example, if their friends were killed in the war, and they witnessed this killing process. So these flashbacks will be very annoying and very will lead them to get to the deep depression, and they can't get rid of these flashbacks from their mind. It's like a tape recorder, they are spinning around these traumatic events. They have several symptoms: the poor appetite, poor concentration, the deep depression, thoughts of suicide, the permanent thoughts of getting out of this situation, nihilistic relationship towards the future. They don't see their future in a positive way. So this is a post-traumatic stress disorder. Acute stress disorder, which lasts more than 1 month. Okay. Post-traumatic stress disorder lasts more than 1 month, up to even 1 year. If we will not intervene as soon as possible, the person might even commit a suicide, because there is suicidal thoughts, because the person with the PTSD is in a deep depression. That's why we need to intervene as soon as possible. Then we have the acute stress disorder. Acute stress disorder is immediate reaction to the traumatic events. What is the difference between the post-traumatic stress disorder? Post-traumatic stress disorder happens after several period of time after the trauma, and it lasts more than 1 month. And acute stress disorder, it's all the same, but the reaction is acute. That's the difference between the post-traumatic stress disorder and acute stress disorder. And it lasts from 2 days up to 1 month, no more than 1 month. That's how we should differentiate between the post-traumatic stress disorder and acute stress disorder. We need to observe the time duration, how long the symptoms exist. For acute stress disorder, from 2 days up to 1 month. For PTSD, from 1 month and more, up to 1 year. That's the difference between acute stress disorder and post-traumatic stress disorder. So what is the treatment? Still the same. We have depression, we have anxiety. We should treat with benzodiazepines, with antidepressants, SSRIs, plus the psychotherapy, CBT or psychodynamic therapy. These are the major treatment options. And the last one in the anxiety disorders, in the list of anxiety disorders, is a generalized anxiety disorders. Why it is generalized? Because it lasts more than 6 months. The excessive worries without a reason lasts more than 6 months. Having an anxiety for 1 or 2 days, it's even normal. But when you're worrying without any dangerous stimuli, and you have this excessive worries more than 6 months, it's already a generalized anxiety disorder, which led to the depression. So what is the treatment of generalized anxiety disorder? Again, benzodiazepines, and by all means, in generalized anxiety disorder, we already have the depression. because after 6 months of permanent worries and excessive worries, the person getting depressed because the person can't realize the way out of this anxiety disorder, and he sees the future in a very black colors, and at the end the person is getting depressed. So in generalized anxiety disorder, we have also a depression. So we need to treat the generalized anxiety disorder with the benzodiazepines plus SSRIs. The psychotherapy here, it's still the CBT. Remember, benzodiazepines, SSRIs, and CBTs are the most effective treatment options in treating the anxiety disorders. Okay? So once again, I would like to summarize the subtypes of the anxiety disorders. These are panic disorders with or without agoraphobia and claustrophobia, social phobia and specific phobia, obsessive compulsive disorder, PTSD or post-traumatic stress disorder, and ASD or acute stress disorder, and GAD or generalized anxiety disorder. The treatment options, I told you, benzodiazepines plus SSRIs. In some specific cases, we can use the beta blockers and plus the CBT or cognitive behavioral therapy. That was about the anxiety disorders. Now I would like to switch to the psychotic disorders. So psychotic disorders I will compare with the schizophrenia, because besides schizophrenia, we have other psychotic disorders which resembles the schizophrenia, and we need to understand what is the difference and how we should differentiate between the schizophrenia and other psychotic disorders. Well, other psychotic disorders also divided into several subtypes, and these are delusional disorder, schizoaffective disorder, shared psychotic disorder, schizophreniform disorder, brief psychotic disorder, psychotic disorder due to medical condition, and psychotic disorder due to substance abuse disorders, okay, or secondary psychotic disorders. So once again, I'm trying to compare these disorders with the schizophrenia. So I'd like to remind you what are the symptoms of the schizophrenia. You know that in schizophrenia, the major symptoms, for example, of paranoid schizophrenia are delusions and hallucinations. So you might have a question about the delusional disorder. If we have the delusional disorder, we will have the same delusions as we have in the schizophrenia. Then how we should differentiate between the schizophrenia and delusional disorder, right? It will be hard for you to differentiate. But there is one tricky thing which will help you to differentiate. In delusional disorder, we do not have the hallucinations or other psychotic symptoms as we have in schizophrenia. In schizophrenia, we have by all means the hallucinations. This is a necessary thing to have, the hallucinations and delusions. In delusional disorder, we have only delusions. And we have several types of delusions. These might be persecutory delusions, referential delusions, grandiose delusions, erotomanic delusions, nihilistic delusions, and somatic delusions. Let me explain each of these delusions, the meaning of these delusions. The persecutory delusions are when the person thinks that the other person or organization trying to harm him or her. This is the persecutory delusion. Referential delusions believe that the gestures or some commands are directed to you. Okay, these are referential delusions. The belief that the commands and the gestures, well, of other people are directed at you. The grandiose delusions is belief that the person has the exceptional abilities. For example, that they are famous painters or famous writers or famous scientists. These are the delusion of grandeur or grandiose delusions. Erotomanic delusions are when the people think that the strange person is in love with him or her. He or she doesn't even know that person, but he or she believes that the other person is in love with him or her. For real, it is not like that, of course. Nihilistic delusion, it is the belief of some catastrophe. The person believes that in 1 year this will be the end of the universe. This is the nihilistic delusion. And the somatic delusion. Somatic delusion, it's a belief that some bugs are living in your body and trying to communicate with you. These are the somatic delusions. So once again, difference between the schizophrenia and delusional disorder. In delusional disorder, we have only delusions without hallucinations. That's the difference between these two disorders. Next is a schizoaffective disorder. Schizoaffective disorder. In schizoaffective disorder, we have the combination of two disorders. Today, I explained you the bipolar disorder, right? So in schizoaffective disorder, we have combination of schizophrenia plus the bipolar. So it means that we have hallucinations, the symptoms of schizophrenia plus the symptoms of mood disorders. For example, the hallucinations, the delusions, some disorganized speech, disorganized behavior, and plus the mood symptoms. For example, the major depressive disorder. These are the combination of two, the schizoaffective disorder. So, but what is the difference? Sometimes it's hard to differentiate between the schizoaffective disorder, bipolar disorder, or the schizophrenia. But how we should differentiate? This disorder is less severe. It is not led to the impaired functioning. The person can function normally. In schizophrenia and bipolar disorder, the person cannot function properly. These disorders led to the impaired functioning of the personality. So this is the less severe disorder. And here we have the combination of two disorders. That's the difference. Okay. In schizophrenia, we have hallucinations, delusions. In bipolar and mood disorders, we have the manic states and the depression. So in schizoaffective, we have combination of two. That's the difference. And if we observe the severity of symptoms, we can realize that this is a schizoaffective disorder and not schizophrenia or other mood disorders. Then we have the shared psychotic disorder. It's very interesting disorder when two persons share the same delusions. For example, one is a really psychotic person who is really sick, and the other person, for example, a partner, sharing his or her delusions. For example, one is a delusional, really delusional, who is really sick, and the other partner is sharing his or her delusions. This is the shared psychotic disorder. It's really easy to identify because two are the role player in this disorder, but we have to treat this shared psychotic disorder both of the person, because both of them are delusional. Okay. Next is schizophreniform disorder. Schizophreniform disorder is really resembles the schizophrenia. It's sometimes so hard to differentiate between the schizophrenia and the schizophreniform disorder. The only thing we can differentiate between schizophrenia and schizophreniform disorder is a time duration. We know that schizophrenia lasts more than 6 months. So schizophreniform disorder lasts more than 1 month, less than 6 months. So time duration only tells you the difference between the schizophrenia and the schizophreniform disorder. That's the only differentiative sign between the schizophrenia and schizophreniform disorder. For example, if you get the person who is just having the hallucinations and delusions, and the time duration of these hallucinations and delusions is 3 months, you can't get the diagnosis of the schizophrenia or schizophreniform disorder. You have to wait and observe this person, okay? So time duration matters in differentiating schizophreniform disorder or the schizophrenia. Next is a brief psychotic disorder. Here we have the same psychotic symptoms as we have during schizophrenia, and here also the time duration matters. Brief psychotic disorder starts from 1 day up to 1 month. After 1 month, the person is absolutely recovered and there is no any psychotic symptoms. So this is the differentiative sign between the brief psychotic disorder and the schizophrenia. Time, duration, from 1 day to 1 month. Okay? The symptoms are the same. Then we have the psychotic disorders due to medical conditions. These are the secondary psychotic conditions which caused by the primary medical conditions. For example, the brain tumor itself. The brain tumor can cause the psychosis because the brain tumor changes all the biochemistry or the physiology of the brain, and it can cause the psychosis. So what should be the treatment in this case? Of course, we should treat the primary cause. We should first of all make a surgical operation and get rid of the brain tumor and then treat the psychosis. But if it is impossible to get rid of this tumor, of course, then we should treat the psychosis with the proper medications. So, of course, first of all, to differentiate between schizophrenia and psychotic disorders due to medical conditions, first of all, we should identify the reason. What was the reason of these psychotic disorders? Was it the schizophrenia or was it the, some medical condition? And next and the last one here is the psychotic disorders due to substance abuse. And we have these substance use disorders, the lecture, and we know that some substances may cause the psychotic symptoms. For example, we were talking about the hallucinogenic drugs. For example, the LSD. The LSD itself is a hallucinogenic drug, which increases the level of serotonin. And we know that serotonin, high levels of serotonin, may cause the hallucinations and delusions. So if the person gets this hallucinogenic drug, for example, we may have the psychotic disorder. So this is secondary to the secondary. The psychotic disorder is secondary, which is caused by using some substances, for example, LSD in our case, or for example, some other stimulants. It doesn't matter what type of drug is abused. Even the opioids can cause the psychotic disorders. Okay. Because opioids are activating the dopaminergic system, and increased level of dopamine also cause the psychotic symptoms. So in this case, the psychotic disorders are secondary, and still we have to realize what was the reason of these psychotic disorders. Was it the primary psychotic disorder, or was it the secondary caused due to medical condition or due to substance use? So now I would like to focus on the treatment of these disorders. What is the treatment of these disorders? Since the pathophysiology almost the same as we have during the schizophrenia, because in delusional disorder, in schizophreniform, schizoaffective, brief psychotic disorders, we have the same symptoms, which resembles the schizophrenia. We are using the same medications. The same antipsychotic medications are effective in treatment of these other psychotic disorders. We can use neuroleptics, the major neuroleptics, the first or second generation, depends. But most effective nowadays is treatment with the second generation antipsychotic drugs of these disorders. So we may use these disorders and we may use these medications, and these medications will be effective in treating the psychotic disorders. So treatment options are the same as in schizophrenia. So that's what I wanted to tell you about the other psychotic disorders. So today's topic were mood disorders, anxiety disorders, and other psychotic disorders. So if you have now the questions related to these topics, please feel free and ask me, and we'll to answer it.
I collected
Yes.
3 questions for you to ask. So the first one about treatment of the depressions. I have heard that
Yeah.
the patients cannot take monoamine oxidase inhibitors with selective serotonin reuptake inhibitors together.
Yeah.
If so, yet why?
Yes. Well, because MAO inhibitors itself increasing the serotonin. And for example, if you plus at the SSRIs, you are trying to double the effect from the MAO inhibitor and selective serotonin inhibitor, selective serotonin reuptake inhibitors, and you will have a risk to get the serotonin syndrome by combining these two antidepressants together.
Okay, thank you. The second question is about how to differentiate depression from normal sadness or masked depression.
From latent depression.
Sorry, how?
Yeah. The masked depression from the real depression?
Like, yes, or just sadness, just normal sadness.
Well, I told you that to differentiate the real depression from the sad mood, it needs to last at least 2 weeks. If it is a subclinical depression, for example, or major depressive disorder, the sad mood or loss of interest or loss of pleasure should last at least 2 weeks and nearly every day, most of the day. For example, sad mood, it can happen only once in a day, in the morning or in the evening, and it is not a permanent. So we need to have permanent sad mood until 2 weeks and even more to differentiate from the major depressive disorder from just a sad mood. Sad mood should be permanently for 2 weeks.
Okay.
And whole day.
Yes, whole
Yes.
day. Okay. And the third one, how to deal with someone who has delusions.
How to deal with someone who has delusions.
Yes.
We should just prescribe the medications. First of all, we should realize what caused these delusions. Of course, we need, I just told you about the reasons of the delusions. Delusions can be because of the medical condition, so it will be the secondary condition. It can be because of the drug of abuse, or it can be because some infectious disease. It's still a medical condition caused the delusion, or it is a delusional disorder. If it is a delusional disorder, the psychiatrist should identify this. He should by all means prescribe the antipsychotic drugs. By all means, we can't deal with the delusion only with the psychotherapy. It won't help. We can only combine the pharmacological treatment with the psychotherapy, but we can't treat the delusional disorder with only a psychotherapy, because it is on a level of the biochemistry, it is changes of levels of the neurotransmitters, which are responsible for these delusions. It might be serotonin, the abnormal level of serotonin, it might be abnormal level of dopamine. So we need to regulate those chemical substances to get the normal level of these neurotransmitters to get rid of delusions. There is no other way. We need to treat them pharmacological, the delusional disorders. But of course, first of all, we have to realize the reason of these delusions. What caused the delusions?
Okay, thank you for clear answers.
You're welcome, dear. Okay. No more questions? Everything is clear? Okay, guys, then let's finish today's lecture, and thanks for your attention, and the best of luck, and see you on Monday.
Bye.
See you
Thank you.
next. Bye-bye. Well, welcome, dear.